Okie dokie, we're blessed with another Sunday. Ultimate Health on Sunday. Joy 99.7 FM. Pleasure and the honor is mine. The name is Nortey by nature. The program is Ultimate Health. It's a Sunday and I want you to feel the vibe. As we continue our Breast Cancer Awareness Month. So shall we feel the vibe?
Can we dance? Can I show you a dance? Are you ready? About what you go wear, Baba God, he go sort you. He go sort you. Even for the birds and the fish in the sea, Baba God, he dey come through. He dey come through. Make you no stress, you go there alright. Alright. Don't give up, deep there inside. Inside. Oh yeah, move to the dance floor, shake your body and do your best move. See, make you no stress about what you go wear, Baba God, he go sort you. He go sort you.
Yeah, most definitely he'll sort you out.
See, Baba God, he dey come through.
When it comes to your health and your well-being,
you go there alright. Alright.
Ultimate Health will sort you out.
Inside.
Welcome aboard.
Shake your body and do your best move. Do your best move. Ready? You don't feel that vibe.
I know you feel the vibe. Tell a friend to tell a friend. We're on Ultimate Health, Joy 99.7 FM. I know you like it when I get jumpy like that, right? But this whole month of October, we've been pink. We've been talking about breast cancer. We started by setting out with all the information you need to know about early detection and why it's critical, essential, non-negotiable. 4,000 women every year in Ghana diagnosed with breast cancer. Sadly, we lose about half of that number, 2,000 plus every year. A good chunk of that is preventable. We've gone through diagnosis, we've gone through the major treatment modalities, and now we want to zoom in. In the studio once more from the International Maritime Hospital, I have Dr. Anita Owusu-Setre. She's an oncologist. Next to her, I have Dr. Mark Kwame Jadosi. He's head of pharmacology or pharmaceutical, or is it pharmacological services at IMA, yes, International Maritime Hospital. Today we are focusing on chemotherapy, the use of drugs to treat and manage breast cancer. If you have any questions, concerns, experiences, testimonies, you can share with me on WhatsApp 055 11 11 997. We're live on Facebook and YouTube. Breast cancer treatment and management using drugs, chemotherapy. And I've got Dr. Anita Owusu-Sechere with me, and I've got Dr. Mark Jadosi. Docs, good afternoon.
Good afternoon.
Did you feel the vibe?
Yes, except my surname that was changed small.
Owusu-Sechere.
Owusu-Sechere.
Yes. Where did I go and dig Owusu-Sechere? Jeez, I'm so sorry. Boss Director, Minister for Interior in the Owusu-Sechere home. Pardon me. Just before I got on air, I was saying to Anita that Charlie, 3 weeks in a row, it's tough. It's tough. But she's here because she's dedicated and committed.
Exactly.
Yep. Dr. Jadosi, once again, welcome. It's been a while.
Yes.
Yeah. How's IMA?
IMA is jumping and bumping and very pink.
Very
this
pink.
October.
Yeah, you guys, you're really in the business. And it's great to have you help us with the programming. So we want to zoom in, and we've learned, Dr. Owusu-Sechere, that there are various modalities.
Yes.
They may be used in conjunction or alongside each other. Right, but we're separating them so that our listeners can understand. We know that the diagnosis is a hefty one, right? There's a lot of information that those afflicted are processing, right? Afflicted and affected are processing. So we need to break it down. So when we say chemotherapy, I know broadly when we're talking of cancer and many other forms of treatment, chemotherapy is a broad umbrella term. But with regard to breast cancer, what are we talking about?
Okay, so chemotherapy is part of the treatment modalities in managing cancers in general.
Okay.
So looking at Pink October and breast cancer, I will taper more to breast cancer.
Okay.
So chemotherapy is basically a systemic treatment. Systemic means medication that you are given that's going to go through the bloodstream.
Right.
So through the vein.
So the whole system.
Yes.
Right.
Yes.
Okay.
So
because blood goes everywhere.
Yes.
Okay.
Yes. It passes through all the organs. So it's systemic therapy that is used in cancer management to kill cancer cells.
Okay.
Yes.
Right. Systemic, it goes everywhere.
Yes.
All right.
Exactly.
Let's compare or contrast that with the targeted interventions. Okay. What's the difference so that our listeners can understand? If you were doing surgery, you're targeting a particular organ, a particular
so usually
collection of cells.
For the treatment for breast cancer, we have the loco-regional treatment. Loco-regional means local.
Right.
Then regional, you are focusing on a particular point.
Okay.
Then we have the systemic treatment. So with the loco-regional, that's where surgery comes in.
Okay.
Because you are going straight to the breast.
Okay.
Or the axilla, which you call the armpit.
Right.
Or we also have radiotherapy. They are also focusing on that site. So where the breast is, or sometimes they go above the breast.
Okay.
Which just under the clavicle, we call it infraclavicular.
Right.
Then above the clavicle, we call it supraclavicular.
Okay.
So it's more of a regional treatment going on. Now, when we come to the systemic treatment, that's where chemotherapy comes in.
Okay.
And we have the hormonal therapy. We have the target therapy.
Okay.
So I think from our previous discussion, I spoke about the fact that when the biopsy is done,
right,
and the report comes as cancer, there are some receptors we look out for.
Okay.
So based on that receptor status will influence the treatment. Whether this person, you have to eventually be on a hormonal therapy. Okay. And or chemotherapy.
Right.
Yeah.
Okie dokie. So if you've just joined us, it's about 12 minutes past the hour of 2 on Joy 99.7 FM. We're discussing chemotherapy using drugs that are put into your bloodstream on the system to target the cancer cells, right? And I've got an oncologist and a pharmacist, right? Yes. Dr. Jadosi, I mean, very often we talk about the oncologist, we talk about the radiotherapist, and so on and so forth. There's a lot of stuff you do that is related directly to breast cancer or cancer treatment and many other treatments. But let's zoom into breast cancer. What's the role of the pharmacist or the oncology pharmacist when it comes to breast cancer?
Thank you. So the pharmacist is a major partner and on the team, on the from oncology care team.
Right.
So right from when the patient is diagnosed. So, for example, I would say for IMA, we sit in with the oncologist or the oncology specialist when he does consultation.
Okay.
So we are part of that team. Starting from there, we do a lot of patient education.
Okay.
We do dosage calculations. So basically, when they're done with their diagnosis and we figure out what chemo regimen the patient is going to go on,
all right,
we all sit and then figure out the dosing together. We do preparation, medicine preparation, and then even as far as going to educate the patients on how they're going to take their medicines. We review the labs together with all the medical teams, and then we do patient follow-up. And then we help with everything from the infusion site all the way to pain management and basically everything. We're part of the group from beginning to end.
Okay, folks, so you're hearing the pharmacist is part of the multidisciplinary team that investigates, diagnoses, and plans the treatment for breast cancer, right? From the get-go, they are in the picture because as Dr. Let me make it Dr. Anita so that I don't get in trouble. As Dr. Anita said last week, I mean, they consider a whole range of things before deciding what type of breast cancer it is, what kind of cells they are, and so on and so forth. What's your history before they decide on the plan and the path for intervention, right? And Dr. Dwadosi just sharing with you that they are part of that team and they are throughout your breast cancer journey. And therefore, there's a whole lot of, should I say, roles and activities and tasks that they undertake alongside the doctors and the specialists we mentioned.
Exactly.
Right. Okay. So coming back to you, I'll come back to Dr. Dwadosi in a sec. So this decision to use chemotherapy either on its own adjunct or adjuvant or on its own, right? How is that taken?
Okay, so most of the times the decision for chemotherapy is based on the patient's age, the menopausal status, whether you are postmenopausal or premenopausal, the receptor status from your biopsy reports, and also the stage at which you are presenting. So someone will come in, a young lady, premenopausal, the lump is big, about more than 3 centimeters. You know, we have stages, and the stages are based on the sizes we are getting, which we call the TNM staging. So if your size, the lump size about more than 3 centimeters, and you tend to also have some lymph nodes. We spoke about lymph nodes the last time. Lymph nodes in your armpits. Someone like that wouldn't benefit from surgery right away. So that's when we are looking at chemotherapy for the patient. We are looking at chemotherapy for the patient because that person is premenopausal, and if you are going to put that person on a hormonal therapy, it's going to take time for the size to decrease for surgery to be done. So mostly we are looking at neoadjuvant. So neoadjuvant is the chemotherapy is being given to decrease the tumor size just before the surgery can be done. So that's the whole point of neoadjuvant. So we discuss with you, we look out for some things before. So we'll talk about the side effects of chemo, but because of the side effects, there are some labs we will do, some investigations we will do on the heart before we choose, okay, you are fit for this modality of chemotherapy, then we start from there. Then we have the group that they presented very early, the size of the lump is like 1 centimeter. They don't have any lymph nodes, so that's like early stage. Someone like that, the surgeon can discuss with you that, okay, so based on the size and everything, we can do the breast conservation
Right.
That's like you are conserving the breast.
Right.
You are not taking it out, not mastectomy.
Right.
So they take out they do wide local excision. Exactly. Right. They do it for the person. Then afterwards, the surgeon will refer you back to us for chemotherapy. So those group is adjuvant therapy. Right. Adjuvant means you've had your primary surgery, you are now coming for the chemo.
Okay.
Someone will ask, why do I have to come for the chemo?
Okay.
So mostly the surgeon will assess your risk of recurrence, the risk of you getting the cancer again.
Right.
If after the wide local excision, the surgeon thinks that per assessment, this person is likely to come back in the future with another thing, recurrence, the surgeon will refer you back for adjuvant chemotherapy.
Right.
Then we start chemotherapy for those class of people too as well.
Okay, yes. 18 minutes past you have 2 on Joy 99.7 FM. We're taking our time to understand chemotherapy as used in breast cancer treatment. Any questions, concerns are welcome. We're live on Facebook and YouTube, and shortly I will activate the phone lines as well. I have a pharmacist and an oncologist in the studio, and we're digesting and taking the steps slowly so that you can understand. Okay, if you don't get anything, please do send us a question by WhatsApp, and shortly I will activate the phone lines as well. Okay, so these are the different groups.
Yes.
Okay, and these are some of the considerations.
Exactly.
Doc Jadosi, when I read, anytime I'm doing this over the years, I realize from what I get from my resource persons, be they radiotherapists, oncologists, pharmacists, and so on and so forth, I realize that a lot of this has to be and actually is personal care or individualized treatment programs. Many people listen to what they heard happen to somebody or how somebody was treated. Can you comment on that? Because from what Anita has just said, and then, you're planning medications and interventions and so on, it looks like everybody's treatment plan will be and should be different. Am I right?
Yes, you're right. So with cancer treatment or breast cancer treatment in general, the dosing of the medicines or the planning of therapy is very individualized.
Okay.
Because, for example, the dosages for even the different medicines used, if it's the cocktail, 2 or 3 different drugs, are based on a few things: your kidney function, liver function, if medicines go through those 2 organs.
Right.
We look at your body surface area, so your height, weight, your age, other medical conditions you have, and your overall general health, if you can even tolerate the cancer or not.
Okay.
So a lot goes into it, and then we sit and we plan, we go through. It's like a protocol that
so
is
you
followed.
want to be sure that not only are you giving effective treatment, in this sense, drug treatment, but you want to be sure that my body can withstand the treatment.
Yes.
Right?
Exactly.
Yep.
And that it is safe for me.
Yes, and it's safe and you can tolerate it and there will be no side effects, and even if there are side effects, we know how to manage it.
Okay.
And so we do a lot of things up front before you even start. We even discuss your dosing and everything with you, the whole regimen. If it's a 6 cycle, 4 cycle, whatever, you go through it. And aside from that, even money plays a role. Cost of it.
The cost
able
of it.
to afford,
Right.
and family support and a host of other things.
So you may have planned and you've got your plan, you've got whatever you want to use, but you must be sure that the patient or the client can finance
afford
the treatment you're talking over the number of cycles that have been planned.
Exactly.
Can afford, or even the medicines are available in country, because there are a lot of newer therapies that people will qualify for, but they're not even here.
Wow.
Yeah. So
right, this is serious stuff. And coming back to you, Doc Anita, I read and heard also that even if the plan has been put in place, on every session, right, your labs are done and everything to make sure your status is okay to continue.
Yes. So I spoke about the fact that usually, even before the day we talk to you about the chemo regimen we have for you, we do some labs.
Okay.
And we sometimes some of the medication has effect on the heart, so we have to check your heart too as well. Now you will come every 3 weeks. Some of the chemo drugs you might come every 4 weeks for another session.
Okay.
So usually anytime you are coming, we make sure we do labs before you come. So the lab mostly entails your full blood count. So we are looking at your blood level,
right?
Because there's some anemia component when you're on chemotherapy,
right?
We are looking at your neutrophil count, your white blood cell count.
Okay.
We are looking at your platelet count. Then we come to your kidney function. So we have something called EGFR, the rate at which your kidney is filtering waste out of the body. It shouldn't be too low, because at the end of the day, the chemo that's going into your system has to come out.
Has to come out.
Yes. So we look at your kidney function and your liver function as well, because the chemo drugs also has effects on the liver as well, some of the parameters. So we look at some things. If they are fine, you go on with your session. But it doesn't end there. We look at your status, how you are looking, your well-being. There are people that we have something called your performance status. So we have categories of it. They are graded. We look at you, how you'll be able to tolerate the injection today. People come and they don't look too good, and because of that, we have to skip that session, or we give them some days to report back for reassessment.
Right.
Yeah.
Great stuff. 23 minutes past the hour of 2 on Joy 99.7 FM. The program, as always, on a Sunday afternoon is Ultimate Health, your ultimate guide to healthy living with me, Nortey by nature. I'm with the docs, oncologists, pharmacists. They're in the studio. We're continuing our journey. Breast Cancer Awareness Month. We've gotten into treatment and management, and today we are focusing on chemotherapy, where they use drugs, put drugs into your blood system to attack the cancerous cells, right? Dr. Anita said this is systemic because it's put into your system, and therefore the drugs, the medications they use go everywhere, and where they encounter these, should I say, abnormal cells, they'll deal with them, all right? As compared to targeted or localized therapies or interventions that are looking at a particular organ or a particular zone of the body. And we're looking at the considerations. It is not, should I say, casual stuff.
No.
Right? We need to know what we're doing to your body and so on and so forth. And let me just chip this one in. No offense to anybody who practices alternative medicine or anything else. But if you were doing, some people say they are doing herbal. Some people say they are doing this and that, which means that whatever you are taking, you are telling us that you are monitoring what it's doing to all systems of the body on a regular basis before you continue and as you know continue to administer. I doubt if a person doing it outside the regular or the orthodox medical system would have the benefit of this kind of monitoring. Am I right?
You are right, because we've had clients come to us that initially we discussed chemotherapy with them. They read about it, they've heard stories about chemotherapy, so they tell you in your face that they want to try alternative medicine. And after it all, they end up coming back to you that they went and nothing really happened. And in fact, how they are even presenting is even sort of worse than before.
Right.
I don't want to say that the alternative medicine is not good or anything.
Right.
But at the end of the day, there's no monitoring going on.
Right. You need to be monitored.
Exactly. There's no monitoring going on.
Right.
So, and that's not the case when you're on chemotherapy. We monitor you per every cycle you come for.
Right.
We check your labs, your parameters before we put anything into your system.
I can't say, for example, that, okay, I've mobilized the money for the chemo cycle, but labs, also. So can we skip the labs for this cycle? And what you're saying is this has to be done this way, properly.
Yes, please. Yes, please.
Right.
That's global standards, and then global, and then also for safety.
Right.
Safety.
So you, the pharmacist, can come in and say, hang on review or this multidisciplinary review, we have a concern about this or that and that, and the team must take it on.
Yes, and there's been time we've had to change therapy in the middle.
All right.
Of the cycle, like the cycles.
Okay.
You know, just because kidneys went bad or liver went bad or something else happened, the patient's health deteriorated or BP was up, we came and we couldn't and we can't do it.
Exactly.
So, and that's how close we are. Even the other thing I wanted to mention is the fact that even in terms of the administration of the medicines, we use infusion pumps that are programmed to give the medicine over a period.
Right.
Because all of those things are safety things that even reduce side effects and help the medicine work well.
Yeah, we'll get to that because you hear, oh, you're going into our infusion center, you're going here, you're doing this and this and that, and we don't hear too much of that here. Maybe you guys are too busy to talk, right? Not that we don't have them, but I know sometimes we get questions from listeners abroad, and they want to test whether we have that level of specialization, right, in terms of departments and units. We'll be getting there. This one says from Daniel in Tema, I have a 19-year-old brother who has been experiencing certain discharges from his breast. Usually when he presses them, is there anything wrong, and what should be done?
All right.
Anita, you're smiling. I know why. Okay, go ahead.
Okay, so usually for a child a teenager having discharge from the breast, you are concerned. Most of the time you are concerned about some of their hormonal parameters. I think in the previous weeks I spoke about even some people having prolactin being high. Not necessarily is something cancerous. So I would suggest that he gets to a nearby hospital and get it checked. Yes, it can even be a hormonal thing, or they will screen him further. It could also be something else. Right.
Okay. Oye Inafienya, I salute you too, and thanks for welcoming us to your home. Ultimate Health on Joy 99.7 FM. Okay, let's come back. So we've decided we're using chemo.
Yeah.
Now, this is going to be put or infused into the patient's blood. How is it done? And does that mean that nothing is taken orally, right? Because people see, and especially we see a lot of this in the movies, right? And people with all sorts of gadgets and tubes and things. How is chemo administered?
All right. Okay. So.
Okay, I'll come back.
Okay.
Yeah.
Usually, because of the side effects of chemotherapy, sometimes it causes some nausea, vomiting. So we give pre-medication before you report.
Right.
So immediately you consent to chemotherapy, we put you on a schedule. So if you are coming maybe on a Friday, we give you pre-medication to take on Thursday. It should be at least 12 hours before you report.
Okay.
So you take them. We have steroid in them, dexamethasone. We have Nexium to protect. So the steroid has effect on your gastric lining.
Okay.
So we give you something to give you coverage for that. So you take it, then you come. You report on the day of the chemo.
Pre-medication.
Exactly.
So this is not the real McCoy.
No.
We're preparing your body to receive the chemo.
Exactly. And also to reduce the side effects.
Okay.
Yes.
All right.
So you come on that day. We give you some of the pre-medication again. About 30 minutes before the session starts.
You're still testing mic 1 2 1 2.
Exactly. So because of the side effects and everybody and how their bodies are, how they tolerate it.
Okay.
So you are mostly careful. You don't generalize that. Okay, this one will be fine. So
this
let me
dose
skip
is good
it.
for the average
exactly.
Ghanaian. No.
So let me skip it. No, it's a protocol.
Okay.
So you get the pre-medication on that day that you report. We run some infusion, just normal IV fluid, just to at least make your body ready in preparation for the session.
All right.
Yeah. So every chemo and the duration, as Dr. Mark was saying, we perfuse it over a period. Fortunately for IMA, we have perfusion system.
Right.
We have the perfuser.
Right.
So they are there in numbers.
Okay.
So we have a chemo suite.
Right.
Where our patient receiving chemotherapy are relaxed, because you should be relaxed. It's not easy. You should be relaxed, then the perfusion will be going on.
Okay.
When you are done with your session, we run some fluid as well, just to try and wash out the system, like clear the veins sort of. Then afterwards we give you post medication. So you take that to about 12 hours after the chemo.
Okay.
All this is to just reduce the side effects or some of the side effects you are going to experience.
Okay.
Yeah.
Great stuff. Good afternoon, Nortey. Please, I've started my menopausal journey, and about 2 weeks ago, after my period, my breast became heavy and painful. I went for the screening and was asked to do a scan, which I did, and there was nothing there. Do you think I still need to see a doctor because it's still heavy, but the pain is going gradually? I'm 49 years. Thanks. Waiting for your feedback, Tina. So she started menopause
2 weeks ago.
About 2 weeks ago, and then hang on. After my period, my breast became heavy.
Okay. So the breast heaviness started 2 weeks after her menses.
Yeah.
But she's now. Where does the menopause come in?
And that's what I was.
Menopause is when you are not menstruating.
But you are menstruating from what you shared. So okay, after her period, she went for screening. Now, this period related to breast self-screening or clinical examination, you said a week or more after.
Exactly.
After, period. Yes. Okay. So she did that, and she was also experiencing pain, right?
Okay.
Breast felt tender. And she's asking, does she still need to see a doctor?
Okay. So the most important thing
she did a scan as well. And
yes, she's been screened, and I'm sure she did a mammogram because she said she was asked to do a scan afterwards. Right. Usually about 40, we look at mammogram.
Okay.
So if she did that and it was fine, it could be a cyclical mastalgia. People have mastalgia is breast pain.
Breast pain.
And people have that with their cycle sometimes. I don't know if this is new to her cycle. Okay. She's never experienced this, and this is just suddenly coming in. Most of the times, after the screening and everything turns out to be fine, we give you pain medication if it's so bad.
Right.
Then we observe and see.
Okay.
Most of the times, with cyclical mastalgia, it should get better. And I think she even mentioned it's gradually. She said it's new. Okay, right. So I mean, I'm glad she went for screening because it's new.
It's new.
Yes,
okay.
It's not something she's used to.
She's on the right path.
Exactly. So she did the right thing by actually going for screening. But the fact that she's been cleared from the screening, if she did a mammogram followed by a scan and it was fine, she shouldn't be worried. Gradually the pain will go.
Okay.
Yes, gradually the pain
it's
will
already
go.
going, Tina. Okay. Right. If you have your question, experience, concern, 055-11-11-997. That's my WhatsApp on Ultimate Health here at Joy 99.7 FM. The program is Ultimate Health. Okay, so Doc Jadosi, so she mentioned, the preparation pre-meds and all that, okay? And you are in the thick of all that, I suppose.
Yes.
Right? Can you talk a bit more about that? People say, well, okay, so are you just going in and your first time, meaning that your body hasn't experienced these drugs before, right? A lot of work up and blood work and other clinicals have been done to get you to that point. So am I going to feel anything? Is it hot? Is it cold? What is it like when you say chemo? I understand what you're doing and why, but what should I expect? How does it feel?
So with chemotherapy, after diagnosis and all the whole 9 years to figure out what you have to be on, depending on what type of breast cancer you have,
okay,
the therapy is determined. And for chemo, typically, there's either the single agent or multiple agent chemotherapy, where you may have 3 drugs on the average.
Okay.
And based on this, I have to state that you mentioned targeted therapy. Targeted therapy, chemotherapy can also have targeted therapies within, where even though it goes to the bloodstream, it goes to target certain parts of the cell cycle during multiplication or during the growth part of it. Okay. So there are different drugs that come in when it comes to chemotherapy. I'll start from the pre-medicines. Pre-medicines are based on the cocktail you are getting and the side effects that we anticipate. Okay. And pre-medicines can be given anywhere from 30 minutes before chemo or 1 or 2 days before. Okay. So sometimes when people are coming on a Monday or Tuesday, we tell them start taking your dexamethasone or your other medications. So these
are the pre-meds are things that are given to the patient to take and administer at home.
Yeah, so depending on the type of cancer cocktail you have,
right,
the regimen, you may take pre-medicines 1 or 2 days before because of the anticipated side effects from the therapy.
All right.
And then on the day off, we give you also half hour before the infusion starts. Okay. And then when you go, like she said, after you're done with the therapy, depending on the regimen that was given to you, some do not require a post-medication. Okay. Some do require a post-medication.
You guys make it sound so simple. Right, but let me ask, so the pre-meds are primarily or typically oral meds?
They are oral tablets, and then on the day of some are IV, injectable.
Okay.
Yes.
So the ones you take home typically will be
oral. Yeah. So either prednisolone, the steroids typically, and then the antihistamines. Some of the chemotherapies cause a release of histamine, which can lead to reactions, anaphylactic reactions, or rash, or things like that. So those things actually are given to you to block those effects when you give the cancer medications.
All right. Now you keep mentioning cocktail. It gives people other ideas, but cocktail meaning more than one drug.
More than one drug.
Right.
So so we also mentioned regimen. So you may, depending on what we are treating, there may be you may see things like on the day of infusion, there are 3 drugs that we bring to you, and all these medicines are targeted towards one treatment.
Okay.
But they work. They use they come in. They use different mechanisms,
different modes of
to
action,
attack them. Different modes of action. Yes.
Okay.
To attack the cancer cell, and some of them actually may not even go and kill the cell, but they work to lessen the side effect of another one. On the body.
Right.
So, yes.
Okay. And then the team would have determined that you need all of these.
Yes.
Right.
Yes.
In your plan, your regimen, for us to get full and efficacious impact. All right?
Yes.
Exactly.
Okay. Right. Now, so the person is going to have this over a period of time.
Exactly.
Okay? And I hear you say cycles, which means that if it is Nortey is coming in for his session of chemo. All right.
Exactly.
The same way somebody might go in for dialysis. Okay. So is it an in-out? Is it a day thing? I'm not going to be admitted. Do I just go in, you zap me, and then I come out? I mean, what is the cycle and what is the ratio? Of course, you've explained that this would be determined and informed by what the person can tolerate.
Exactly.
But what can you give us a general overview?
All right. Yeah. So on a regular day, if you walk in for your chemo session, we've already done your labs before that session. So you see a doctor.
Right.
Most of the times, if you don't get to see me, there's an oncology nurse around.
Okay.
So she can even text me the result, or she looks through the labs.
Okay.
So I see the labs. If they are fine, go ahead is given for the patient. Sometimes too, we look at your general, in fact, most of the times, your general appearance, as I mentioned, whether you look good, ready for the chemo or not. So you are ready for the chemo, you look good, we send you to the chemo suite.
Yeah, in good standing.
Exactly. Your performance status is good.
Okay.
Yes, ECOG 0. So we send you to your chemo suite or the chemo suite. The pharmacists are always around, so they are known.
That's the same or the equivalent of an infusion center.
Exactly.
Right, a specialized place where you go to receive your chemo.
Exactly.
Okay.
So the pharmacists are known that you are around. So they start with the preparation, but they mostly come with the pre-medication. So the nurses, the oncology nurses, will administer that. Okay. All through that. In fact, if it's your first time, as you are consenting to the chemo, we talk to you about the side effects, what to expect and all. So mostly as patients are coming that day for the chemo, they are aware of most of the side effects they are going to experience. Some of the side effects are acute, some too are long term. So you come in, the pre-medications are administered, your vitals are checked, your BP, your pulse, your saturation. We have people that come in, high BP is 200. We can't give the chemo.
Okay.
Yes. So
we are not in good standing.
Exactly. So your vitals are checked, chemo pre-meds are given. Then the pharmacist actually brings the chemo, the drug itself. So we use the perfuser to administer over a period. Some people, their own is like 3 hours. Some people 4 hours. Some people 6 hours. They are done with the whole session.
So the perfuser is an equipment that is, should I say, pumping or whatever the medication according to whatever specifications over a period.
Exactly.
Yeah, so it's like a machine that you go to the ward and sometimes you see an IV hanging on a pole. Yeah. And then there's a line, an infusion line, and then it goes into the vein. So this one, the machine comes to the middle. Because of the safety aspect, you can tell the machine to administer a 200 ml bag over 10 minutes.
Over 10 minutes.
Yes, or 15 minutes or 30 minutes or 2 hours.
Right.
And it's able to do it for you compared with, what you usually will see with the...
Which is
the manual way where the thing is, and you
Right.
can't really. And a lot of these medicines are supposed to be given over specific periods.
Everything is specified.
Specified,
Right.
yes. So without that machine,
So this is
typically
automated,
it's automated,
and
yes.
then you can program it.
And it's
to
programmable,
do
yes.
It specifically.
Yes.
Right. Okay.
So usually all the IVs we bring from the pharmacy are labeled, okay, if it's supposed to be given over an hour, we actually write the patient's name, instructions, the drug name, everything, how
Okay.
it was mixed, and we indicate infuse this over an hour.
Okay.
So that the nurses are able to program that and then to make sure that, and usually sometimes when side effects will happen, it's either because you give the medicine too fast or something untoward
Okay.
comes with
But
administration.
at all times you are under monitoring.
Yes.
Yes, there's always a nurse sitting there. Yes.
There's a nurse, there's the equipment, everything that is monitoring and checking
Yes.
everything that is being administered,
Yes.
right? And of course, your records are there as well.
Exactly.
Okay, right. 43 minutes past the hour of 2 on Joy 99.7 FM. This is getting very technical, but I know my listeners, having listened to Ultimate Health for more than 23 years, you should know what we're doing. I'm going to activate the phone line 0302 216-541 0302-216-541. We're live on Facebook and YouTube. You can send your questions also by WhatsApp. In the studio with me, Dr. Anita Owusu-Afriye. She's an oncologist with the International Maritime Hospital. And next to her is Dr. Mark Kwame Jadosi. He's head of pharmacological services or pharmaceutical services at IMA. And we're talking about chemotherapy with regard to breast cancer. All right. So my phone line is active 030-221-6541. You can get in on the action and ask your questions. If you can, make them brief. Having said that, wow, there's a long WhatsApp message. Good afternoon, Nortey. How are you and your noble team? I thank you for the good work you and your team are doing during this October. I must be with you from the beginning, but due to the spillage of the Volta, made my house flood and I'm struggling to pack my belongings. I'm so sorry. That make me late to join you. Now, my question about when the drug is being put into the system of the affected person, how fast can the medicine work to reduce the pain the person is going through? So you've gotten to pain already, right? It's one of the known symptoms or side effects, but it's you make it seem as if as soon as it starts, there's pain, right? I've watched many videos. I've listened to several narratives from patients. It doesn't always include pain, but Hayford in Bato is asking, how fast can the medicine work to reduce the pain?
So the drug doesn't cause pain as you are there, right? Like when you are getting it, no. But usually some people later start having side effects from the drug, which sometimes we have people come in with neuropathic pain and all that. But if you are having chemo, and at any point we see you in so much pain,
right,
we give you something immediately to stop the pain.
Okay.
Mostly we go for the opioids. Example is the morphine. So either IV morphine, just to get the pain out.
Okay.
Some come in and they have so much pain from the sides, the breast.
Right.
Some come in, the cancer cells has already gone to the bone, so there is so much pain.
Right.
Back pain. We won't just sit there, watch you get the chemo and go. No, no doctor will do that.
Yeah.
We even give you the pain medication first before the drug, because the drug, there's no way the drug is going to cause pain at that instance. But if you, the patient, you are in pain, we give you something for the pain before.
All right. Okay, this one is from Erica Bozo Nkrakane. He's calling me a DJ because of the feel the vibe. Thanks, Eric. This is from Dede, Maryland. Hello, the lady who did the mammogram and scan and there was nothing. I'm still uneasy with no peace of mind. Can I request a biopsy to put my mind at rest? This is from Dede in Maryland, USA. I think she's referring to the earlier, right, Tina's question, but she's saying she's feeling uneasy if it. Using the scenario, can she request
So I don't know what her mammogram and scan report said.
Right.
She said they told her it was fine.
Yeah.
I think the last time we spoke about the stages after your mammogram.
Right.
BIRAD 0, BIRAD 1 up to 6. So usually it depends. If it's BIRAD 1, that means it's negative finding. They didn't find anything in it at all.
Okay.
So mostly when you are going into biopsy, you are wondering what you are going to biopsy.
Right.
So honestly, it depends on what the report was.
Okay.
For that lady, because sometimes there could be nothing in it, but they recommend you come after 6 months for a repeat scan.
All right.
Yes,
That's
but I think
surveillance.
she did. Yes, but she didn't really give us the detail of what the report said.
Right.
All she said was they said it was fine.
Yeah, she wanted to know if she
so
was okay.
maybe
Right.
she can just go to the hospital
follow
and
up.
and clarify that. Yeah.
Okay, right. 47 minutes past the hour. We have about 13 minutes on Ultimate Health. We're talking about chemotherapy. Right. So the person goes in, has the infusions and all that done. Right. We've talked about some of the side effects. Okay. We mentioned nausea, pain. Some people have pain at the site and so on. What are the others? And of course, I know people are waiting to hear hair loss and a few other things. In fact, I was listening to one of the YouTube videos, and they have dietitians. They have a whole. In fact, their team itself is a cocktail.
It's like that in
Right,
Tema.
and I listened to the video, and someone on the video they said they can even give you recommendations if you need a wig.
Yeah,
they measure,
They measure you for a wig.
That's
size,
yes.
Oh boy.
Yes.
They'll get you a wig. But
Yes.
you ladies are wearing wigs
already.
already.
No, you know, women, we love our natural hair. I mean, every lady. Sometimes you just want to.
I beg you. Let's not go. Let's not go. If we go into women and hair and wigs, but let's talk about hair loss. All right. We know this attacks the cells in various ways,
Exactly.
various chemicals or various drugs, right? But one of the collateral side effects is hair loss. Okay. Why does this happen? And okay, I seen somebody sent me their report.
Okay.
I'll get to that in a second. But why does this happen?
The hair loss.
The hair loss and a few
So
other things.
usually, sorry, what happens with the chemotherapy is the main target is the cancer cells, but unfortunately, the drug is not able to differentiate normal cells from the cancer cells.
Okay.
So there's always a little effect on normal cells. The reason for some of the side effects. But the good thing is the normal cells are able to repair themselves.
Yeah.
So they get back to, how they used to be.
Okay.
Then the chemo has effect on now killing the cancer cells.
Right.
So immediately it's targeting some of the normal cells. You know that some of these side effects are going to show up.
Okay.
So the reason for some of these side effects.
Okie dokie. All right. So all those mouth ulcers
Yes,
and
exactly.
the
mouth
vaginal
sore.
dryness and all those things are related
Yes, exactly.
to the damage or collateral damage on normal cells.
And then the fatigue.
Fatigue, right.
Yes, the blood disorders. So hair loss, we mentioned that. And then the pain as well. She mentioned pain. And then even in long term, sometimes people may develop what we call the chemo brain.
Right.
Where they are focusing or their memory can be affected a little bit. Some do recover, some do not.
cognitive
Yeah.
And
deficits.
then, but fatigue is one of some of the things that people do.
Right.
And then maybe lack of or even energy to perform like they used to perform.
Yeah.
All right, great. My phone line is active 030-221-6541. 10 minutes to go. I know you guys, you finished your Sunday fufu and things, and then you come in. Tina has sent us her report.
Okay.
Left breast shows a well-defined hypoechoic lesion with echogenic central part measuring with volume of 0.58 mil. The right breast shows normal fibroadipoglandular tissue. Tina, you buy me lunch. There is no mass lesion, architectural distortion, or microcalcifications noted. Right? All these were not there.
Yeah.
Right? The overlying skin and subcutaneous tissue are unremarkable. Both axillae are normal in echo pattern. No axillary lymph nodes seen bilaterally.
Okay.
Right? Left breast intramammary lymph node otherwise normal breast scan.
Yeah, but if I got Tina's age right, she said she's 49.
49, yeah.
So I was actually expecting a mammogram before a scan.
Okay.
So if she can clarify whether she did a mammogram.
This is a breast USG.
Yes,
right?
usually,
Ultrasound,
usually
ultrasound.
40 and above. A mammogram is better.
So this is an ultrasound.
Yes,
Okay.
but a scan should follow a mammogram.
Okay.
Yes, and the mammogram will let us actually get a correct picture looking at her age. So I don't know if she skipped the mammogram part.
Okay.
But if she skipped, then I would suggest she gets a mammogram.
Okay.
She said only
Before
scan.
biopsy,
Only
that's
scan.
Yes, so she
Right.
should have. Yes, she should have. She has to get a mammogram.
Okie dokie. All right, Tina. Thanks for sharing with your name and everything, but we're here. Okay. Very often when I follow up, the name is probably not even Tina, but it's Tina on the report. This one again from the day. My former boss went through chemo and she lost her hair. When the hair started growing, it changed from Pinkpeshi. As for you, Dede, you are in Maryland, but you are local breed. Okay, Pinkpeshi to the kind of silky curly hair. Have your resource persons heard or seen this? Will your hair type change? What causes that? Is it the chemo meds?
Genetic.
So it's a whole genetic thing going on.
Alright.
In fact, the whole cancer thing is like there's a genetic mutation. So your DNA, with the cells, there's been an alteration and all that. So personally, all my patients that their hair grow back, it doesn't grow back like how it used to be.
Okay.
But some of them, it actually grows back nicely.
We are a brunica.
Yes, like, it actually comes out nice, like very silky hair and all that. Most of those
silky. Is that a loss or a gain?
which one is
When she is stubborn hair.
Oh,
The
okay.
hard hair, local breed. Unadulterated, local.
can't
But
form.
so these are disturbing to a lot of women. Essentially or primarily we're talking about women. These are disturbing should I say side effects.
Yes.
Right? So I guess you guys have a team, so you have all sorts of support, education and all that to deal with these side effects.
Yes.
So we're saying that the chemicals so administered over the period of time should control the cancerous cells. So would that be classified or termed cure?
Okay.
For many people, I've done chemo, but they are not telling me it's gone. How do you measure or monitor what you're doing and whether it's having an impact, the desired impact? And does it have a should I say, a destination or end point where you say you are clear? There are many people who are declared or classified survivors, right? Is there a point where you say, okay, we don't see anything again?
So I think I spoke about the groups for the chemo, the adjuvant therapy people, those who have had surgeries and surgeon thinks or feels they will need chemo, then they come back to us.
Okay.
So mostly they get the chemo done, then based on their report, if there will be a need for radiotherapy, they get that done.
Okay.
Usually for the adjuvant therapy people, you are done with the treatment after the chemo, and if they will need radiotherapy, they've gone through that. Some people, based on their hormonal receptor status, you put them on hormonal tablets.
Okay.
The tablets, so they are going to be on it for 5 years. They take it every day for
That
5
means
years.
their type of cells respond
exactly.
to hormones.
Yes, exactly.
Okay.
So they are fortunate they are going to be on medication for 5 years.
Okay.
So what they will be doing is to be coming for follow-up, 3 months follow-up, 4 months follow-up. After the 5 years, they'll be coming for yearly follow-up. So in that group, immediately you are done with the treatment and you are just coming for follow-up, we can put you in the survivor group because you've gone through a complete cancer treatment.
Right.
Then we have the neoadjuvant, those that are coming to us with the big lumps to make the size decrease and the surgeon will assess for surgery.
Okay.
So to assess their response to the chemo, you first of all, when they come to you the first day, you measure the mass, the lump.
Right.
Then as you are getting the chemo, you keep measuring it.
See the decrease.
So yes, exactly. So there should be decrease alongside.
Okay.
After they are done with their session, sometimes you tell them they will have 4 cycles. So every 3 weeks they are coming for 4 times. Sometimes we do a mammogram, a repeat mammogram, just to see how it is now looking after the session. Then if it's good response, you let them go to the surgeon, then the surgeon will decide what to do.
Okay.
Then we have those that when they came to you, the cancer has already gone, it's metastatic.
Right.
It's gone to the liver. Yes,
right.
exactly. It's gone to the liver, it's gone to the lung, the bones. So those group of people, they will be on the chemo, or sometimes based on their status, if you think they can't even tolerate the chemo and their hormone receptors are positive, you put them on the pill.
Right.
So we have the group that they don't have any positive hormone receptors. That's a triple negative.
Okay.
So for that group, they are not going to be on any pill.
Right.
It's just a chemo.
Right.
When they are done, they come for follow-up. So if you come to us triple negative, it has spread metastatic, you are going to be on the chemo. So assuming you came, they saw about 5 nodules in your lungs.
Right.
As you are getting the chemo, after like 3 sessions, we repeat the scan to see that has the 3 nodules increased, or it is still 3, or it has come down. So if it's still 3, that's what most people call stable disease. It's not progressing. You are there. If it has increased, that's progressive disease.
Right.
So although you are metastatic, you are still progressing, although you are on chemo.
Right.
So those kind of people, that means you have to change the regimen.
Okay.
Then you look for another thing. So usually for the metastatic people, they tend to be on chemo for some time, a longer time.
Right.
Yes.
Because you are trying not to make their condition worse, although it has spread to other organs.
Okay.
So they mostly are on it for quite a long time as compared to the other groups.
So
yes.
Underscoring what we said from the onset, that early diagnosis, identification and diagnosis is critical.
Yeah, exactly.
Right? Because if it's spread, okay, we can chase it with the systemic chemo.
Exactly.
But so I didn't want to ask this, but so what's our prognosis here? Even though it's individualized, right? It's spread or it's at this stage, what are we really doing? We're slowing it down. Right?
Exactly. So usually for the metastatic group, what you are doing, the palliative care, that's how we call it.
Okay.
So it's like you are not curing anything.
Right.
You are just trying to make their stay comfortable.
Right.
And manage all their symptoms.
Okay.
So any symptom they are having, you take them out of that symptom.
Okay.
Some come to you in severe back pain. You have to manage that for them.
Right.
Some come to you anemia, you manage it for them. So with the palliative group, you are not really curing anything.
Right.
It's just supportive management.
Yes. Keeping you comfortable.
Yes.
And that. But with the earlier detection and the lower stages or earlier stages.
Exactly. You can at least.
You can actually get to a point.
Exactly. You can cure. That one you can go for curative chemotherapy. Whatever they are getting is to cure.
Okay.
It's not palliative.
All right.
Yes, exactly.
Okay. And then also with the ones that you said we're doing
neoadjuvant, exactly.
And all that.
Yes.
There's also going to be a
cure,
surgery.
exactly.
Right.
Yes.
So you're doing chemo, but there'll be a follow-up surgery.
Exactly.
Right. So the chemo is just to help, support. Right.
To shrink it. Yes, to shrink the tumor.
Make it more amenable for surgical intervention.
Exactly.
Right.
Yeah.
Wow.
And after you remove, it's possible to also do chemo again if there's a little bit of the cancer left.
Okay.
To make sure it's totally eradicated.
Right. We've run out of time, but one of the things I wanted to ask, how many of you guys do we have out there? How many specialized suites with the multidisciplinary teams? I've heard of nurse coordinators, your nurse this, outside they say nurse oncologist. Here we say oncology nurse, right? And so on and so forth. Do we have the cadres we need, the specialized professionals?
Exactly.
To do all the multidisciplinary stuff.
Yes, exactly. So in IMA, as I was saying, anytime when you come for our clinic, the pharmacist is there, the oncology nurse is there, plus the clinician. We see the patient. Then, based on patient's acceptance of the condition, if we have to refer it to a psychologist, we do that. Some people, as they are on the chemo, they start losing weight. They are not tolerating food. So we involve the dietitian.
Comes in.
Yes, exactly. We involve the dietitian. So, in fact, the whole team is set.
Right.
Yes.
Okay.
Yeah.
So, if there's any member of the team, Dr. Jadosi, that you don't have, does that mean that they'll be called in as what?
Yes. So sometimes we call specialists in.
Okay.
But I wanted to touch more on the national thing.
Right.
Nationally, I think we still need to train quite a few more people, from the pharmacists to the nurses to the doctors, and then also equip more facilities to be able to handle these things at the world-class level.
Right.
Because I think we are still way behind.
So we need to look at personnel.
Yes, personnel, and then infrastructure. Because Ghana is way behind when it comes to cancer treatment. Are we getting people specializing in these, for example, oncology pharmacists? Yes, the Ghana College is training people, and then the Ghana College of Physicians and Surgeons are also training people. Okay. And West Africa is also training. I know the nurses are also doing programs for people, but what we need now is the technology one and then the infrastructure. Okay. Because I know nationally, almost every teaching hospital now has started cancer treatment. Okay. But in terms of what they need to treat at the world level, right? We'll dedicate some time to that after we've done the month itself. Yes. Right? We'll look at the need for specialized, qualified teams that are, should I say, properly remunerated at that level, so that they'll stay here. Exactly. Because we might build the capacity and they'll leave the country and go elsewhere. Yeah. Right, which is happening in other sectors. All right. But when you create the environment, typically they won't leave. Okay. Because when they enjoy what they do,
you are saying that because you are here.
No, I came back.
You came back. I know.
Yes, I came back.
Right. Okay. So we'll have to wrap it up. Many thanks, Dr. Anita. Also free.
All right.
Right. I'll make that mistake again. And Dr. Mark Jadosi, this has been very interesting. I'm sure we'll have to take another slice of it, but I want to do radiotherapy. All right. Right. And then be able to do a wrap up with you guys at IMA. IMA has been great to us this month, and we're most grateful. But we'll take a slice of radiotherapy, and then we'll come back, probably do a multiple with the surgeon and then the other pharmacists and all that. All right. Thank you so much.
You're welcome.
All right. Thank you so much, my discerning listeners. Thank you, Abeku, for the few extra minutes. Stick and stay on Joy 99.7 FM. My name is Nortey Dua.